Yeah, so I hope the screen is visible. Hello, everybody. I'm Dr. Nikhil Arbatti from Mumbai, and I'm thankful to the ASICON committee for giving me an opportunity to speak today. Today's topic is about percutaneous vertebroplasty. So, what does percutaneous vertebroplasty mean? It's basically the injection of a PMMA cement into an osteoporotic fractured vertebra, which is not showing any signs of healing, even after a period of conservative trial, leading to pain and affection in active daily life. So, what are the benefits of doing vertebroplasty? Apart from the fact that it gives an adequate pain relief, it helps in early mobilization of patients who have this osteoporotic fracture. Majority of these patients are geriatric patients, so these require early mobilization. Thus, it prevents in the comorbidities worsening directly. Also, it prevents, if it's a junction level fracture, it prevents the collapse from worsening. As in this case, if the patient had been treated adequately before, the collapse would have been prevented from worsening. There are certain indications of doing a vertebroplasty. First of all, our osteoporotic fracture, which has got a conservative trial of 3 to 4 weeks and is not showing any signs of adding a pain relief. Patients who have comorbidities and are totally non-ambulatory because of the pain, they need to consider vertebroplasty. If an MRI picture shows a Kamal sign, that is a non-avascular necrosis or non-union, that is another condition where vertebroplasty needs to be considered. Also, if it's a pathological fracture because of a tumor where a palliative surgery such as injecting cement is to be considered, as in the multiple myeloma, then that are other indications. Definitely, vertebroplasty comes with its complications. There are some immediate complications like an extravasation of cement into the epidural space, which can lead to neurological complications, an extravasation of cement anteriorly into the paraspinal veins, which can lead to other serious complications. There is also the chances of extravasation of cement into the superior inferior disc space. This, apart from the fact that there are certain hypertension which can happen while injecting the cement because of an embolus which can be thrown up. There are some delayed complications, that is an adjacent level fracture which can happen. Also, the vertebroplasty injected bone, if there is a fall in the future and if that bone gets affected, the cement does not get integrated into the bone. So the chances are that the cement block can sometimes hit your pulse. You should definitely not consider a vertebroplasty when there is a severe osteoporotic fracture, which can lead to stenosis and there are neurological symptoms because of it. If there is a burst type of fracture pattern where the cement can get pushed out or can get extravasate very easily, you should not consider a vertebroplasty. More than 60-70% collapse where it will be very difficult to negotiate needle into it and put cement, definitely you should not consider doing a vertebroplasty. Apart from the routine things that you should not do a vertebroplasty in a traumatic fractures. There are some cases where it depends upon whether the vertebroplasty needs to be done or not, depending upon the surgeon's preference. If the fracture is less than 3 weeks, but if the patient is severely non-ambulatory because of the pain, is not able to walk, and is having comorbidities, then you can consider doing a vertebroplasty in such cases. If if the collapse is more than 50% and in X-ray and MRI it appears difficult to negotiate a needle, but if the surgeon has an adequate, uh, what you would say, experience of negotiating it, then it can be considered. More than two level fractures, depending upon what is the amount extent of collapse. If the collapse is not severe and you feel that you can inject 3 to 4 cc of cement into every vertebral level, you can consider it. 3 levels is maximum that I've done at one time. A junctional level where there is a compression, and there is minor cord compression without any severe stenosis and no deficits, you can consider of doing a vertebroplasty. At the higher level, about D6 or D7, if you feel that the pedicles are adequate and where there is no severe compression of vertical compression of the osteoporotic fracture, and you will be able to inject an adequate amount of cement into it, you can consider doing it. So these are the cases which depends upon the surgeon's preference and his experience. So how does this vertebroplasty help? So actually there is no confirmed theory in how it works, but one of the theory postulated is that the heat generated by injecting the cement causes neuroablation of the nerves leading to pain reduction. What would be the ideal case to start if you're doing a vertebroplasty? The fracture, if it's between D11 to L3, the vertical compression fracture should not be more than 40 to 50%. You should have an intact pedicle so that you can easily cross the needle lid and with an intact morphology of the vertebra. Definitely not any burst fracture, so that there should not be an extra recession of the cement. And if possible, at least 2 to 3 weeks of period of conservative trial post this fracture should have been done. Some investigations which are necessary before going through the vertebroplastic procedure is, apart from the supine X-ray, see if you can get a standing X-ray. This is necessary so that you can determine the amount of collapse. After doing a standing X-ray, you can also, if possible, get a prone X-ray, because if in the standing X-ray you find that the collapse is significant and you're not sure whether you'll be able to pass the needle or not, then in the prone X-ray, if it's possible, you will be able to see whether the fracture is opening up. An MRI scan is mandatory because this will show the fracture pattern and the morphology, also to say whether the edema is present or not, because if it's an old fracture, definitely it will not accept any cement in it. And if you're not sure whether the fracture is a burst or not, get a CT scan done. Apart from that, the other investigations are, if it's a multiple level fracture seen at the same time, get a serum electrophoresis done to rule out multiple myeloma. You can do your bone densitometry to see what is the bone density, DEXA scan to see what is the bone density, and post treatment, post vertebroplasty, any medical management that is required. Also, if the routine investigation, serum creatinine and all, and which is required, because procedures are usually done under local and sedation. You require a proper sterile OT and a C-arm where you can easily see an AP laterally properly. If you have two C-arms, then it is also reduces your operating time significantly. Make sure that the temperature of the OT is properly controlled. It should be between 18 to 20 degrees. These procedures are done under local and sedation. You should have a good anesthetist who can give a proper sedation without making the patient too sleepy. You may require a deep sedation only when you're injecting the cement, because that is when the patient may experience some amount of elevated pain. If you're doing more than 2 levels at a single sitting, you can use 2% silocaine mixed with adrenaline, or 2% silocaine is enough if you're doing at a single level. If you want to use a dye after putting the cement in, after putting the needle into place before injecting the cement, you can use an Omnipack or a Eurocapsule dye. So the technique basically involves advancing a J needle or a Cook's needle through the pedicle through the 3 o'clock or 9 o'clock position, depending upon the pedicle. And under C-arm guidance, you advance the needle up to the anterior 1/3 part of the body. Once the needle is confirmed in that position, in AP and lateral view, you can use a dye to inject into that space first through the needle to make sure that there's no extra recession. Once everything is confirmed, you can just pass the cement into that needle. About 3 to 5 cc cement can be easily passed. So, an illustration of it, this is where we start at the 9 o'clock position. You usually inject a little bit of local around the lateral part of the pedicle, and this is where we make a stab incision in the skin adjoining to that lateral part of the pedicle. You can advance the Jamshedi needle up to the lateral part of the pedicle in the AP and the lateral view so that you get a good hold. Further advancement of the Jamshedi needle in the AP and lateral view should be done under proper C-arm guidance. Make sure that the Jamshedi needle travels through the pedicle as it travels through a small cylinder. So always make sure that the Jamshedi needle is positioned into the AP and lateral views. In the final position, before advancing further, it should be in the medial part of the pedicle and should have crossed the posterior vertebral line in the lateral view. As in this, yeah. The final placement is it should be in the anterior 1/3 part of the vertebra, and once it's confirmed there, you can just inject it and check the spread. To illustrate, you should have the C-arm and a technician who can show a proper AP view where the pedicles are both seen properly. You can always orient the C-arm in such a way that the pedicles are seen properly and you see a dead AP and a dead lateral view. Then in the AP view, inject the local around the lateral part of the pedicle, 2% silocaine. If you're doing more than 2 levels, you can use 2% silocaine mixed with adrenaline. After injecting the local, give it sufficient amount of time for that local to act. So maybe after a minute or minute and a half, you can just with a stab knife in 11 gauge or a 15 gauge, make a stab incision on the lateral part of the pedicle adjoining the skin. Then with the Jamshedi needle in the AP, you can start advancing it up to the lateral, in the lateral part of the pedicle in the 9 o'clock position. Check in the AP. Usually sometimes this osteoporotic vertebra have a very weak bone and the needle can suddenly give way. So in the lateral part of the pedicle, in the 9 o'clock position, make sure that the needle gets a proper good hold. Once you're satisfied with the hold, then you can ask the CM technician to rotate the CM and make it lateral view to make sure that the needle is advancing properly in the lateral view. It's not too superior or inferior. So once it's confirmed in lateral view that the position is proper, you can advance the needle further. So you can keep on doing twisting movements and rotating movements to advance the needle in osteoporotic this thing. Need not always hammer it unless there is some amount of sclerosis present, if it's a little bit old fracture and you need to push the needle with force. Otherwise, majority of the times with the twisting movement, you can advance the needle further. So always keep on checking the AP and lateral views to make sure this, once it is positioned properly where the needle is placed, yeah, in the lateral view in the anterior 1/3 part of the vertebral body, you can just do a final arrangement so that the needle is placed there, and once it's confirmed that it is there, you can just check it. That does not give it this thing. I usually do it with this thing. So this is where the final placement of the needle should be, in the anterior 1/3 part of the body. And I usually don't inject any dye into it, but if you want, you can inject a dye to make sure there is no extraversion of cement going to be. Then you can start mixing the cement and inject the cement in a semi-solid state. Usually 3 to 5 cc of PMMA cement can be injected at one level through one pedicle. Do it under continuous fluoro and don't all push the cement in so that it does not extravase it out. This is how the final picture appears after doing a single level vertebroplasty. Once the procedure is done, remove the Jamshedi needle, allow at least total setting time of the cement should be around 15 minutes. So give that much amount of time till the patient remains prone. Once that time has elapsed, the cement has hardened exteriorly, then you can just put a small dressing, a cell strip over it, and then make the patient supine again. Thank you.